Welcome to Endo Untangled, where we pull apart the science and the stories behind endometriosis, pelvic pain, and everything connected. I am Dr Alicia Macro, GP and women's health doctor, and I'm joined, as always, by my lovely co-host, Cherie Noble, accredited exercise physiologist. And today, we're getting to the guts of it, quite literally. We're talking about the bowel, the bit no one really wants to talk about, but everyone with pelvic pain should. What's actually happening when you can't poop properly, even though your colonoscopy looks normal? Why do so many people with endometriosis have bowel symptoms? And what on earth does it mean when a colorectal surgeon says the anus only exists to keep the flies out?
I'm really looking forward to that question being answered.
We have some flies in the studio with us today. My guest today is Dr Chris Gillespie, a colorectal surgeon based in Brisbane and co-founder of the Queensland Pelvic Floor Centre. Chris leads one of Australia's leading multidisciplinary pelvic floor services, working with nurses, allied health clinicians and specialists to help people with complex bowel and pelvic floor problems, from difficulty emptying to incontinence and pelvic pain. He has a special interest in the functional side of colorectal health, using tools like anorectal manometry and endo-anal ultrasound to understand what's really happening when the anatomy looks fine, but things still aren't working. Chris is known for his clear, down-to-earth explanations and for helping patients feel seen, understood, and often, finally, relieved. Chris, welcome to the podcast.
Welcome.
Thanks so much, Alicia. Thanks, Cherie. Thanks for the invitation.
Oh, we're so excited to have you here. Probably more than is healthy. Do you think, Cherie?
I think we've got a fascination with all things bowel and
health.
Relieving bowel health. Yeah,
Absolutely.
it's so important. And we were discussing off air how pivotal it is in pelvic pain and, well, with everyone really, and how it's a topic that we don't want to discuss and we kind of shy away from. So this is a really important discussion that I think we're going to have.
So, Chris, before we get into the nitty-gritty of the bowels, I always love to start our podcast by finding a little bit out about our guest. So I get the feeling from hearing you talk that you had at least some bit of life experience before becoming a surgeon. I'd love to hear a bit about what led you from being a New Zealand kid through to being a pelvic floor and colorectal surgeon.
Yeah, thanks. It's all a bit serendipitous, I guess. Going back, I never knew this. I'd end up working in Australia, living in Brisbane, and doing this. But it's how things have ended up. And like everyone, it's just been a fun journey along the way. And I guess I started off working in a small country town in New Zealand, and I think it was we were sort of thrown in the deep end a bit there. There were no registrars, no sort of fellows. We worked directly with the consultants in a small town, and so we got quite a sort of broad experience at that time, and I think a good grounding in just sort of basic medicine and how to actually be a doctor. And I really think I learned a lot about how to be a doctor there. And I did actually have, believe it or not, a really brief stint for 6 months working in a general practice quite early on. And I've had a huge respect for GPs because I went in knowing absolutely nothing. I could do chest pain, I could do abdominal pain, and that's not really a lot of what you see in general practice. It's a whole range of all kinds of things. And but having that experience was probably one of the times I really felt like an actual real doctor. I then sort of worked a bit around the world. I worked in the UK, I worked in Ireland and Scotland for a while, and ended up going back to this country town, and then just sort of had a bit of a light bulb moment where I started realizing that surgery was interesting and fascinating, and ended up moving to Melbourne, where I did most of my general surgery. Finished general surgical training, still with no real idea of this thing called the pelvic floor. I got into training in colorectal surgery, and then did my first job in Auckland, and they had a thing called a pelvic floor multidisciplinary meeting, and I still remember my first one. I had no idea what they were talking about, but I thought it was fascinating. And throughout that year, I started suddenly realizing that all these people that I'd been seeing for years and years beforehand had an underlying functional problem intimately linked to their surgical problem, their hemorrhoids, their fissures, their fistulas, and I started slowly over time really realizing that there was a strong link between these things, and that really to get a good outcome, you needed to understand these other disorders and be able to treat them as well. And then over time, I started working in Queensland, where there was a need for a colorectal pelvic floor service, and I just happened to be Johnny on the spot at the time. It was in a smaller hospital called QE2 here in Brisbane, where there was already a good urogynecology team who did a really good job, and a good functional urology team. And it's sort of one of those fields that a smaller hospital was ideal, and a big hospital, sort of cancer and trauma and these bigger things sort of end up trumping functional stuff, unfortunately, very sadly. But we were able to set up the service, and it just sort of grew and grew. And then suddenly the next thing you know, there's a tsunami of patients out there with these functional problems, toileting problems, can't poo problems, leakage problems, having trouble holding on problems. And they're all linked to problems in the middle, what we call the middle compartment, vaginal problems, bladder problems. And when you do set up a service that actually properly addresses these patients, it's incredible how satisfied the patients can be, how happy they can be, finally feeling that their problems are addressed. And I find it personally very satisfying. Often, ironically, more satisfying than treating cancer and things like that is taking someone who's suffered for years and years, and with some terrible life limiting, debilitating problem, and being able to improve their quality of life. And it's just sort of grown, to be honest, from there, and set up the service in public at QE2, and then we opened a similar service in the private sector, and sort of realized that when we all work together, you do get a good outcome. And I've learned a lot from all of the other people in our team, the allied health professionals, the physiotherapists, the urogynecologists, gastroenterologists, etc.
You can see why I've been fangirling Dr. Chris, don't you, Cherie?
Absolutely. So many things to pick up on there. But I think, and I think that this is something we talked about off air, is that you mentioned functional a few times, and this term functional bowel and functional approach. Can you tell us a little bit more about that and your approach?
Yeah, well, I guess what is functional? I mean, I think one of the problems, particularly with bowel management and workup of bowel symptoms, is that in Australia, and not just Australia, to be honest, around the world, there's this massive focus on cancer. Could this be something serious? And it's really important to make sure it isn't something serious, because things like bowel cancer and Crohn's disease and these kind of other disorders are very serious and important to diagnose. But there seems to be an excessive emphasis on excluding those things, and then don't worry about it. It's not something serious, so don't worry about it. So one of the basic tests for bowel symptoms is a colonoscopy. A lot of people who present with bowel symptoms may end up having a colonoscopy. And as I say, I'm a fan of a colonoscopy. It's a very important test, but it's really only a test for a growth or inflammation. It is not a test for any of these other functional disorders. You can have a normal colonoscopy and have terrible incontinence or terrible constipation, or terrible pelvic pain and other symptoms. And the danger with that is that people end up just being dismissed and told sort of there's nothing wrong. So functional, I guess, is when anatomically there's no lump, there's nothing I can put an arrow on and say, look, there's the problem, there's the growth, there's the lump, there's the inflamed area. Functional is when the problem is more that the system does not work. And so I guess to understand when something doesn't work, you have to first of all understand, well, what is normal? How do things work in the first place? And so in the pelvis is an amazing part of the body that's used every single day. If we just look at the bowel side of the pelvis, our rectum's job is to store stool. And we are able to defer going to the toilet until a suitable time when we can find a toilet. Obviously, that's a really useful thing to be able to do. It's an emptying mechanism, so we're able to fully empty our rectum and a lot of our left colon in one movement. We don't leak. So the skin around the perineum is not designed to be moist. And we know that if you look at a baby with nappy rash, it's designed to be dry so that the anus and rectum doesn't leak. And if we need to go to the toilet and we're not near one, we can hold on. So we have an ability to defer going to the toilet. And functional disorders refer to when one of those functions we're not able to do. So we're not able to empty properly. We're not able to hold on. We're not able to not leak. And often coexisting with those problems are symptoms related to what else is in the pelvis. So we've got the middle compartment, the reproductive organs. So there may be issues related to pain with intercourse. There may be issues related to vaginal prolapse. And then there may be issues related to the bladder. So ability to empty your bladder, ability to hold on, ability to sleep through the night without having to get up multiple times to go to the toilet. These are all things that we take for granted when we're normal, and we realize how important those functions are when we lose that ability, and it can be devastating to people who when they suffer from problems related to these important pelvic functions.
Chris, I'm just wondering if you can talk us through, and I love talking about this myself, but I think the actual process of doing a poo, of defecating, is, I explained this to someone in clinic today actually, it's quite an elegant process, I think. There's a lot of things happening in a normal bowel function in careful choreography that allows us to do a poo in a way that is healthy and normal. And what I have, which you won't be able to see unfortunately, is just a couple of very simple slides. One is a slide of a pelvis cut in half down the middle showing what you call, so is anterior compartment including bladder, or is that middle compartment?
That's including bladder.
Okay, right. So we've got bladder for those assigned for female at birth and women. We've got uterus, and then in the back we've got the bowel and the rectum coming down, sitting in a basket of pelvic floor. And in the other slide that we will show, there is a very simple diagram showing the way that the bowel comes down with a sling around it, of the bowel kind of being held shut by the puborectalis muscle. And I would love for our listeners to, after listening to this, feel that they know their puborectalis muscle, and their puborectalis muscle is their friend. I wonder if you can just talk us through, what's a normal pooing process look like?
Yeah, sure.
Good question. Okay. What is a normal pooing process?
Yeah, great question. Really important question. And yes, I will definitely talk about the puborectalis muscle, which is a really important, the most important part of continence, and a very important muscle. So the first thing to say is that this is all run by our subconscious brain. This is a reflex, a bit like breathing. We're always breathing. We don't have to think about it. It just happens. The pelvic floor is constantly active. The pelvic floor is constantly active, stopping you leaking feces and stopping you leaking urine. And so we have the rectum, and the rectum, I guess, is, if you like, the reservoir. And it's a reservoir that sits in your pelvis, and there are lots of connections from your rectum to your subconscious brain. So there's always talk going on between your subconscious brain and your pelvic floor. It's a very active system, and that's why we talk about the brain-gut axis and things like that. So at rest, there's a muscle called the puborectalis muscle, and this is a sling muscle, and it's active. It's contracting all the time, and it wraps around the back of the rectum, and it holds the rectum forward, and it holds the bladder closed at the same time. As I say, it's the most important muscle in preventing leakage. We also have below that something called an anal canal and an anal sphincter, and that's also actively closed. The sphincter is more a secondary mechanism, so that any small amounts of poo or small amounts of mucus that may leak through don't leak out of your anus. So these two things work together, but by far the most important muscle is that puborectalis muscle, which is active at rest. And that muscle is creating a right angle, essentially, in your anus and rectum. So if you do a rectal examination, you put your finger inside someone's anus, it'll actually go right over a right angle. And so that right angle is where your rectum is actually being pulled closed by that muscle. When we go to the toilet, we don't know what we do. It's a reflex. We do some kind of push, and that's about as much as we know as humans. But what happens in the pelvis is amazing. And the first thing that happens is that puborectalis muscle lets go, and the sphincter also relaxes. There are other muscles that are actually attached to your rectum. So the puborectalis muscle, as I said, that wraps around the outside of your rectum, is not attached to your rectum. It pulls it closed like a sling. But there are other muscles. There's the levator plate at the back, attached to the back of the rectum, and parts of the iliococcygeus muscle, which are attached to the front of the rectum. When you go to the toilet, these muscles contract. And when they contract, they actively pull open the anus. And in doing that, the anus will more than double in its diameter. So the resistance to flow massively reduces. That right angle that I talked about straightens out. And now, with a generation of a bit of pressure in your abdomen, with your abdominal muscles and your diaphragm and your paraspinal muscles. So defecation is a really complex maneuver involving all of these muscles, what we call the abdominopelvic cylinder. You're able to generate a bit of pressure, but now with an open anus, and you're able to push something from inside you outside you. The same muscle that pulls your rectum forward also closes your bladder, which is why it's quite difficult to wee and poo at exactly the same time if you've ever tried to do that. If that muscle relaxes, then the levator plate will pull backwards, keeping your rectum closed but opening the bladder. And so that's when you pass urine. And then when you're finished, obviously everything goes back to that resting state. These muscles control the great creator, God, whoever it is that you believe in. Rather than creating some muscles for the bowel, some muscles for the bladder, some muscles for sexual function, just sort of said, look, let's just make everything control everything. And so these muscles are all involved in the control of the bowel and the bladder and sexual function, which is why it's so common that we see patients who have a combination of symptoms. So, it's very common that I'll see people with bowel symptoms. They might come to me with problems controlling their bowel or problems emptying their bowel, but they'll also have, say, some vaginal prolapse or vaginal symptoms, and also potentially some bladder symptoms as well, because it's all one unit, and it's all controlled by this amazing outlet that, as I say, we take for granted. But it can become dysfunctional, and it can become dysfunctional when we have things like psychological distress. So psychological distress and inner turmoil can very much manifest in this part of our body, where these muscles can go into what we call protection mode. And it sort of makes sense. It's an intimate, sensitive part of your body. Your sexual organs are there. So these muscles can go into sort of protection mode, and that can be very good for protecting you, but not so good for allowing normal function of your bowel or normal function of your bladder. And then you can thereby sometimes run into trouble.
Yeah, I can imagine that sort of protective mode, the purpose of that was to protect you for a short period of time, if you're being chased by the lion or whatever it is. But
Yes.
what I see as a GP working with women with endometriosis and pelvic pain is that protect mode is just on all the time, and often has been on for months and years. And it might have been kicked off by the pain associated with chronic bad periods or with endometriosis pain, but not always. I mean, sometimes that process is kicked off by trauma, sexual trauma. I see a lot
Absolutely.
of, and I have seen it in other things, even recurrent urinary tract infection, and I have seen it happen with someone who's had a couple of episodes of even a bacterial gastroenteritis was enough to sort of set their pelvic floor into protect mode. And I would say for those who are listening to the podcast, if they have or they love someone who has pelvic pain, endometriosis, that their pelvic floor is almost always in protect mode, and that makes their bowels go off the dials weird. And that is why we've got you here today, because I don't think I've seen anyone with complex pelvic pain without pelvic floor and bowel problems. And many of them have had, as you have mentioned, they've had a colonoscopy, they've had their surgeon or gastroenterologist come out to them in that post-operative period when they're waking up, say, no, it was all good, back to your GP, and
Nothing to worry about.
Which is great. I mean, we don't want them to have anything that we can see, but the question's always, okay, what
now?
Well, what's going?
Yeah.
How do we explain what's going on and what next? So what I'd like to just find out about is how, in the patients that you see, for example, how pelvic floor dysfunction might show up in terms of symptoms of their bowel that you will see. And I know that you're not a fan of the term constipation necessarily. So could you talk us through?
That?
Okay, talk us through
there, maybe.
how it shows up and what's the matter with the word constipation?
Yeah. Well, the problem is that I don't really know what constipation is, and I don't. I think when a patient comes in and says they're constipated, it can mean many things. And what I mean by that is I want to work out what it is that the patient's describing, because they might, to one patient, constipation might mean that they don't get much of an urge to go to the toilet. To someone else, it might mean that they don't go very often. To someone else, it might mean that their stool is hard. To someone else, it might mean that they can go to the toilet, but they find it really difficult to go. And to someone else, it might mean that they've got a lot of abdominal pain, for example. And so I like to clarify what a patient means when they say certain things. And so if someone says to me, I've got constipation, my first line usually is, what do you mean by that? And then sort of clarify exactly what is the symptom that's bothering them. In terms of symptoms, just to sort of run through that, some of the most common symptoms that people describe are what we as doctors call obstructed defecation. In other words, difficulty getting the stool out. And so there's a number of questions that I ask when I have a patient in front of me. The first thing is, do you feel after you've gone to the toilet that you're empty? And a surprising number of people feel that they're not. They feel there's something left, or they know there's something left, sometimes to the point that half an hour later they'll return to the toilet again because they've got to get that next bit out. And we call that encore defecation. Some people strain. Encore. Some people strain or push really hard. Some people need to manually help themselves to get stool out. And so often they'll use the finger or something like that, and they may need to put that in the rectum. They may need to put that in the vagina. They may need to support some area around their anus. That some people even massage their abdomen to help them go to the toilet. I often ask about leakage. So leakage means something leaking out of the anus in between going to the toilet, usually without any warning. Often people will say they've sworn they've cleaned themselves, they've wiped themselves clean, they're sure they're clean, but then half an hour later they come back to go for a wee and there's moisture there, and it might be mucus or it might be a small amount of poo. And we call that passive leakage. Other people might describe not being able to get to the toilet in time, or just knowing that they need to know where toilets are because they're unable to hold on to stool for a period of time. It might be that they're unable to control gas, or they might be unable to control a solid stool. Obviously, if they have a liquid stool, say if they have a dodgy curry the night before, they're going to be in a lot of trouble. And some of these people will modify their entire life.
It sounds very stressful. Like, this is very stressful, which is then I could imagine that feed forward loop then of,
100%. And so they call it the key and door syndrome, where just as you put your key in your front door, that's when you're really desperate to go. So there is psychology involved, but it can be a genuine thing where you're just unable to hold on. And some people will stay at home and not leave home till 10, 11 in the morning because going to the toilet is such a difficulty for them, and they don't want to leave until they're empty because they're worried that they're going to have an accident, which is highly, highly embarrassing.
Yeah, and can I ask, Chris, is there a delay in seeking, assistance and treatment with this? Is this what you find?
There's delays everywhere.
Yeah,
there's delays everywhere. So there's first of all a delay, and there's a lot of embarrassment. People don't realize how common the problem is, and often there's a perception that maybe nothing can be done, and there's also a perception that it's normal, which is quite sad. A perception that it's normal after having a baby for a woman to have these symptoms, or a perception that it's a normal part of aging as well. And sure, these things do occur more as you get older, but they're also treatable. So there's sometimes with quite simple measures, for example, medications or some supplements or the input of an allied health practitioner, we can really turn patients' lives around. And so there are things that can be done. So there's delays in seeking care. And then a lot of medical practitioners out there are not aware of the treatment options that are available, including some of the more invasive things like sacral nerve stimulators or other anti-prolapse procedures, which also can equally be life-changing for many patients. And so I think, that's one of the important things to realize. And this is a podcast on endometriosis, so there's a huge crossover with endometriosis. Endometriosis is really an inflammatory condition, the way I see it, where from your first period, every month, you've got this ectopic endometrium where it shouldn't be in your pelvis. And you've got, when you have menstruation, there's inflammation. And the way I describe it to patients is I say, imagine I took a cigarette butt and I burnt your shoulder in the same place every month for years and years and years. And then I came to you 10 or 20 years later and I rubbed that part of your skin. It's going to be really sensitive. You're not going to like it. And the same thing happens in the pelvis. So you get this really sensitized pelvis. And because these muscles are under subconscious control, they react and become hypertonic and dysfunctional as a result of this constant inflammation and what the body perceives as injury for years and years and years. And you can be a great surgeon, and endometriosis surgery is very powerful, and you can do a great operation and remove all of that endometriotic tissue. But the problem is that damage has been done, and those muscles remember. And they're traumatized from those years and years of what the body perceives as injury, and they remain hypertonic and they remain dysfunctional, and that can drive ongoing pain and it can drive ongoing dysfunctions. So you have these frustrated patients, I've had my endometriosis surgery, but I've still got this problem with my bowels, and that's why they have it. And so these patients need more care. We've just got to keep working away because there's still things we can do to try to alleviate some of that sensitivity and some of that muscular dysfunction, and that may lead to improvement in quality of life and improvement in function for these patients. And equally, it's important before surgery to set expectations correctly. Yes, we have very good surgeons in Australia, and we can do very good operations for endometriosis, but does a perfect operation equal a perfect outcome? Not necessarily. There may be other measures that we need to do to try to give you an optimal outcome from treatment for endometriosis.
This man is such an icon. That is just the best. Thank you. I mean, I think there'll be so many people listening to this who are like, oh, this makes sense. Because, I mean, if you look in the forums, which I do occasionally, there is so much confusion and frustration and distress out there with patients trying to understand why they've had the best surgeries and the best treatment and they still are struggling. That's such a fantastic, wonderful explanation. So thank you.
And I guess even just reconfirming about this, is it one thing or is it five things? And I know that we've had patients who are like diagnosed with IBS or all sorts of different things, and it's so confusing. And it is that, where do we start?
IBS is a common one, and IBS, irritable bowel syndrome, is really a syndrome where pain is a main characteristic. And interestingly, the diagnostic criteria for irritable bowel syndrome involve bowel symptoms. So pain related to going to the toilet, pain relieved by going to the toilet, pain worsened by going to the toilet. And I think there's a massive crossover between what is termed irritable bowel syndrome and pelvic floor dysfunction. There is genuinely some patients who have a very sensitized bowel. They can develop a sensitized bowel. And I think that's what we really mean when we say irritable bowel. But a lot of patients with irritable bowel syndrome actually have a pelvic floor disorder. And there's good evidence now that if you're able to treat that pelvic floor disorder, improve their emptying, their IBS symptoms get better. Surprise, surprise, because a lot of these patients will actually complain of the abdominal component of the problem. So they'll complain about the abdominal pain. They'll complain about the bloating and sometimes the feeling sick, and often certain foods, particularly things like dairy or gluten or FODMAP foods, make these symptoms worse because those foods tend to lead to a stronger gastrocolic reflex. So you've got this colon pushing to try to empty because something's going in the top end, but it can't empty because of a functional problem or a mechanical problem. And so your pain gets worse and your bloating gets worse and your cramps get worse. And often these people do feel better when they avoid those foods, but they're not fixed. They remain still suffering from this problem because the underlying problem is at the other end.
And that's definitely what we see. So your explanations are incredible. This is, I think it's our listeners are really going to be thinking about, this topic, as we've said, that's not talked about enough, and potentially because of embarrassment or not knowing what's normal. So I think it's been incredible to unpack what's normal.
One of the things I wanted to ask you about, Chris, is what I see a lot is where constipation or problems with defecation, problems with going to the toilet, actually shows up as what people think is being diarrhea.
Yeah.
And if I could just briefly talk you through some, I guess I'll try and de-identify some patients that I've seen, but one in particular is someone who has terrible tummy pain and is having terrible recurrent nocturnal, like overnight and in the evening, diarrhea that is incredibly painful and distressing. And I could do an MRI, and I have done an MRI looking for endo in someone like this. And we may not find endo, or we might, but also what we find is a mini football, those footballs that little kids play with, of what looks like concrete poo. Yes. But this person's problem is not constipation, it's diarrhea, and trying to help someone who's struggling with that's really hard.
Yes.
So it was the poo that's stuck in their belly. Can you talk us through how you would approach something like that and how you might conceptualize something like that?
Yeah, again, this goes back to the words constipation and diarrhea. And I think as humans, the thing is we don't have much to go on, right? We've got what comes out. We measure it. We measure everything that's happening in this really complex GI tract by what we produce at the bottom end. And if it's loose, we think that must mean intestinal hurry and things are going through too quickly. And if it's the other way around, then we presume things are too slow. But particularly in elderly people, one of the most common causes of incontinence or diarrhea is actually constipation. And so what's happening there is that you've got someone who has a non-emptied colon, so they're not very good at emptying their bowel over a very long period of time. In most of the patients that we see, it's years, usually decades, that they haven't emptied their bowel for a very long period of time. And then eventually what happens, and the underlying problem is that their outlet does not empty adequately. And so when we go to the toilet, we assume that what we're seeing on the outside is the same as what was on the inside, but it's not always the case. So it might be that we've got a normal stool inside our rectum, but because our muscles are so dysfunctional and we don't open our anus, and we've got this really tight pubirectalis muscle that doesn't let go, and we're pushing like crazy against this non-opened anus, which is a very, very common problem, the stool comes out loose. And people will often say it comes out as explosive diarrhea. They'll use the terms explosive diarrhea. And they'll assume the problem is diarrhea, but actually the problem is that they're not emptying adequately. And the way that their pelvic floor is processing the stool is it's rendering it liquid as it's coming out. And so these patients are actually constipated, if you like. In other words, they're not emptying adequately. And so what often happens in a patient like you're describing is that they haven't emptied for a very long period of time. They've got this chronically high pressure, full colon, and it's painful. And when they eat certain foods, that pain gets worse, because when they eat certain foods, their colon contracts, and they often feel very bloated. And then they'll have times where they've got, if you like, overflow, or they're only able to allow a small amount of this big impacted stool out, and they'll think they've got diarrhea, but they don't. So that patient needs to be treated. We need to empty that patient. And so we need to understand why is it that patient is not emptying adequately. And a lot of the time it'll be a functional issue with the way their pelvic floor is acting, or it may be a mechanical issue. It may be that from straining for years and years and decades, the supports to the rectum and to the pelvis have become so stretched that biomechanically the rectum is now not able to empty so well. And so that patient may need enemas, they may need suppositories, They may even need to be taught to irrigate their anus. They'll need some laxatives from the top end. They'll need the input of specialist pelvic floor physiotherapists to try to get that pelvic floor acting more physiologically and able to empty adequately. And once that rectum and colon is able to be emptied adequately, their pain should get better. And that nocturnal diarrhea what they call nocturnal diarrhea should get better, because they're not walking around with a rectum that's constantly full anymore. So the problem there is that the rectum's not being emptied and it's just constantly full and stretched. And in someone like that, it may be that, I don't know what age that patient is, but it may be that they've had this problem for such a long period of time that everything's become so stretched that there's only going to be a degree of reversibility. This problem may not be completely reversible, and it might be that to keep that patient as well as we can, we've got to do maintenance. So we've got to have them on laxatives regularly, which is completely safe. We've got to have them maybe using enemas or suppositories, maybe even every day. Some patients even irrigate their anus with water, a small percentage of patients, where it's necessary, and they find that their life is much better if they do that. This is obviously for the more severe end of the spectrum, but absolutely that kind of patient probably has a chronically non-emptied colon for one of the reasons that I've mentioned.
It's so hard, Chris, because for someone who's coming in to see me because their biggest problem is diarrhea, to say that they need to have more laxatives, they should have enemas. They look at me like I've got two heads. They're like, are you listening to me? Because, I mean, I've seen someone who lives on GastroStop to deal with their explosive diarrhea, which is, taking something to treat their diarrhea when it appears that it's not diarrhea. It's secondary to the dysfunctional bowel, and that's really hard. And I think just even awareness, like being able to have this discussion that people can listen to in a safe place in their own time, to go, oh, is my doctor insane or not? And is this worth a go? Because I often say to people in clinic, I know this is going to take a bit of a leap of faith, that if you've come in to see me with diarrhea and I'm saying, let's talk about some things to get your bowels moving through, but that we can't, we must do that.
It sounds like, from what you're saying, is that potentially we're making some assumptions, and that is detracting from the actual picture of what's really going on, and symptoms don't necessarily mean that that's what's really going on. So there needs to be the correct diagnosis of what's actually happening for that person. And then it sounds like, everyone's kind of working very similar who's doing, this sort of care well, is that you've got this whole range of toolbox, but unless you've got the right problem, like, how do you know what tool to pull out?
Yeah, well, we don't have X-ray vision. We can't see what's going on inside our abdomen. So sometimes those scans I find are quite helpful. Like actually the one you were talking about before, Alicia, showing that patient the MRI and saying, look, this is what's inside your pelvis. You're actually completely chocker. Or just doing a plain abdominal X-ray for these patients, just to show them that actually they might think they've got diarrhea, but actually their colon is totally loaded. And I think that just if you're able to show that, most people will grasp that.
It's just that we don't have this information out there. Like, if you stopped people on the street, I don't think that there's many people who would actually know about a normal poo and what we should be looking for.
But even clinically, I think, and this is a way that my practice has changed in the last couple of years, is that I find it really interesting when my patients coming in with pelvic pain have presented to, say, an emergency department and understandably had a CT done while they've got pain. And I find it really helpful to actually go in and have a look at the pictures on their CT or on their MRI or on their X-ray, if that's what I've got, because I find it fascinating how often the really severe pelvic pain patients of mine who are presenting to EDs with pain are just so loaded fecally all the way through, or they're locally, it's in the sigmorectal, which makes sense, like the bit down the end towards the end of the bowel. But the other one is sometimes it's actually just right-sided. It's on the beginning bit of the large bowel. But yes, I do find that helpful, and actually being able to show my patients, hey, this is part of what's going on, and I often find it's not reported in the radiologist report.
That's very true. That's very true. Because these patients, they've got this, what I call a functional outlet obstruction. So then the muscles are cranked up, they're sensitive, they're dysfunctional, they're unhappy, and so your poor rectum and your poor colon are not emptied. And if that happens over a long period of time, and your colon is just not emptied for years and years or decades and decades, eventually your colon gets stretched, because your colon's job is just to deliver stool to your rectum and anus. Your rectum and anus have a much more harder job of being able to empty it. And if your colon is not emptied for a long period of time, it becomes stretched. And then after a period of time, it becomes so stretched that it becomes dysmotile, and it becomes not so good at delivering stuff down to the rectum. So then you've got another problem compounding the symptoms. And a lot of these patients that, they sort of get told, oh, just have some laxatives. And that's part of the solution, but often it doesn't necessarily make these patients better, because the problem isn't that their stool is too hard. The problem is much more complex. It's that this really important part of their body, their pelvis, is not able to empty their stool properly. And so laxatives doesn't fix that. Laxatives may help it. In some cases, if a fiber supplement will actually worsen those symptoms. These people are working around with a big high pressure colon, and then they're told to have some Metamucil or Benefiber, and they load their colon with even more fiber, and it remains unemptied, and their symptoms get worse. So what these patients really need is a much more complex treatment to try to improve emptying, and that may involve what we call biofeedback therapy, which is done by specialist pelvic floor physiotherapists whose job is to try to treat that sensitivity, treat that hypertonia, and get the pelvic floor and the pelvis working more physiologically so that it's able to actually empty better. And then maybe after that, chase the patient with some laxatives or something from above. Sometimes patients even benefit from a Botox injection. So patients who are really tight and really cranked up or in a lot of pain, they might see myself for a Botox injection, for example, a colorectal surgeon, to try to paralyze those muscles that are tight and dysfunctional. Or they may see a specialist gynecologist who may put Botox into these same muscles to treat severe pain. And so what these patients need is not something simple. And I think that's part of the problem. Patients want a simple fix, and a lot of doctors want to give them a simple fix, but it actually needs a team approach. Sometimes psychologists, psychiatrists, there may be a lot of psychological elements going on, physiotherapist, gynecologist, maybe a colorectal surgeon, maybe a gastroenterologist, a very important person, obviously the GP as well. And they need all of those people. And I think, that's really what we've realized in Queensland. And I think that's why, these centers that we've set up have been successful, is that we're able to actually provide what people need, which is not one person. And there's evidence for this now that patients do better with multidisciplinary care because of these factors. It's not easy. These are actually complex problems, and these patients need a lot of care and a lot of love, and it takes a lot of time. It's not easy, and it's not a quick fix. But when you do provide them with that care, it's incredible some of the outcomes you can get.
Hallelujah. Sing it from the rooftops. Dr. Chris, before we get into some more management, which I'd love to do with you towards the end, but let's talk about diagnosis and investigations. Yep. You're right. We live in a world where, particularly in first world medicine, particularly in the bowel, we are all about let's make sure that there's not a nasty process going on. We don't want to miss anyone who could have a cancer in their bowel. We don't want to miss anyone who could have a Crohn's or an ulcerative colitis, of course.
Yeah.
But most of the people I've seen have had those tests. Many have had those tests done multiple times, have had multiple colonoscopies. They're all normal.
Exactly.
Yeah. How can we diagnose these issues better, and how do you do that?
Yeah. Well, yeah, good question. So I start by hearing the patient's story. That's most of what I'm doing, and that takes a fair bit of time to sort of unpack that story. That story might go right back to their childhood. That as you've already talked about, they may sometimes they've struggled with their bowels since they were a kid, and it may be because sadly they had a very difficult childhood or a very traumatic childhood. It might be that they were a victim of, they had an abusive childhood, emotionally, physically, sexually, and so to really understand where a pelvic floor patient is at now, you've got to look at their whole life, and you need to look at their job as well, or the activities that they've had. Have they exposed their pelvis to huge pressures because they decided they wanted to take up heavy weightlifting, or was that part of their job, perhaps? Or have they suffered from significant long-term anxiety or PTSD related to a work event or a life event or something like that? So you sort of have this, you have to have the snapshot of the whole patient's life.
And just going back, sorry to interrupt you, and I don't want to interrupt your flow, but just in terms of jobs, so nurses, you people who can't go to the toilet when they need to go to the toilet, nurses, like junior primary teachers who cannot just leave the kids in their care, probably surgeons.
I mean, I definitely have high stress jobs is what I'd say. So, and also shift work. So people who, they're doing day shift, they're doing night shift. I mean, nurses are your classic example, but there's many fields outside medicine where that's a reality as well, or in the construction industry. So people where there just isn't toilets available, they're moving between different work sites, maybe not a stable thing, and it's actually quite difficult for these people. So toilet availability is a real problem as well. Other people might have just been through really traumatic times, like a long hospitalization because of a critical illness or something like that. Importantly, I take an obstetric history. So about half of what I see is related to obstetric trauma. So specifically, I'm talking about a traumatic vaginal delivery there. And so that's usually one of my opening questions is, do you have any kids? Any vaginal deliveries, and I sort of screen for whether that delivery may have been traumatic, because it's usually not the entire cause of the patient's problem. It can be in a very traumatic delivery, but it's certainly a player in many cases. So you've got this, you've sort of getting a picture of the problem, and so that the patient will tell you what's bothering them, and every single patient I ask all of the questions that we've talked about. So I ask about difficulties going to the toilet, difficulties holding on, leakage. I ask them about vaginal prolapse, difficulties with intercourse or sexual function. And when I say that, I'm talking about both women and men, and then bladder symptoms as well. And so everyone gets screened, and pain and abdominal symptoms. I've always, as at the end of the day, I'm a doctor. I've always got my ears out and my tentacles out for something else that might be going on. Sometimes patients may have started a new medication that may be implicated. Sometimes, and I'm also screening for other rarer problems. Sometimes someone with a spinal problem, for example, may present with one of these symptoms, but most don't. And I do ask about colonoscopy. Like I said, I don't want to sort of come across saying it's not important. It is important. But most of these people have a normal colonoscopy or a non-contributory colonoscopy, and then we sort of move on from there. The next most important thing is the examination, and so I'm obviously going to look at the patient's abdomen, but specifically I'm going to look at their perineum and their anus, and I'm looking for two things really. I'm looking for what's the function like. So I often will ask patients to try to simulate what they do when they go to the toilet. It's not easy necessarily to do, but with repetition, you can sort of get an idea of what's someone doing, what's their abdomen doing, and what's their pelvic floor doing as they go to the toilet. Is it physiological? Is it normal, or is it abnormal? And is it a major driver to why they're having trouble? And I'll do that, first of all, by looking at the patient just on the outside, just observing, and also with the finger inside the rectum, obviously with the patient's consent. That can tell you a huge amount. You can feel those muscles, and you can feel whether they're doing what they should do or not. And I'm also looking for mechanical dysfunction. So is there a loss of support? Is there significant vaginal prolapse? Has the whole perineum descended because it's not supported anymore? Is the rectum collapsing down into itself, or what we call intersuscepting? Or is there tissue coming externally? Does the patient have large prolapsing hemorrhoids or even rectal prolapse or something like that? And often, to be honest, with a really good history, like I've talked about, and a really good, careful examination, you've got a pretty good idea of what you're dealing with straight off from that. There are some other tests that you've touched on that we do. One of them is endo manometry. So this is where we test.
Thank you for saying that,
Yeah,
Chris.
Sheree, can you ask Dr. Chris about that test that you were wanting to ask him about?
Okay, so Alicia's making fun of me because it's quite a word that's quite difficult to pronounce, and you did that very well. And she's going to make me say,
what was the test that you wanted to ask Dr. Chris about?
I'm going to give it a go, and we can all have a laugh. Anorectal manometry. I couldn't do it. You said it, so I'm not even gonna. I'm not gonna try it. I can't say the manometry. But you said it so eloquently, and as you, we're here to listen to you, not me mess up these words.
But let's talk about manometry.
Manometry, there it is. Manometry. Yes, let's edit that out, Rory.
No way.
Yeah. What is that, though? Tell us.
Yeah, look, what I'd say is it's really adjunctive. So I think, like I said, the history, the story that the patient comes to you, and what you're finding when you examine them are really the key things. These other tests, manometry, sensation testing, endoanal ultrasound, are really adjunctive. They add a little bit and occasionally may give you a bit of extra information, but usually you've got a lot of your information already. The manometry is simply more objective. So it's a probe in the anus, and it's measuring pressure. And it's measuring pressure during different maneuvers. So there's always pressure in our anus because our anus is always closed. Otherwise, we'd all be leaking everywhere, right? So our anus is actively closed. So it's normal to have pressure in your anus. Some people with disordered defecation or dysfunctional pelvic floors, they may walk around with a really, really tight pelvic floor. So the tone will be really high. And normally during defecation, as they try to poo that probe out, the anus should open. They should make it easy for something to come out of their anus. So the pressure should drop to close to zero. So in these patients that I talked about with dysfunctional pelvic floors, you actually see their pressure go sky high, even higher than when you ask them to squeeze their anus. And the use I find of this is that you can show the patient, hey, we talked before about showing them an MRI or an X-ray. You can show the patient on a graph, look, this is what your body's doing. This is what your body should do, but this is what your body's doing. And that's really powerful. Patients love that. And when they can physically see with their eyes what their body's doing. And that's also the basis of biofeedback therapy. Biofeedback therapy simply means that you're given visual feedback or some form of feedback on what your body is biologically doing. So you're able to say to the patient, look, when you do that, that's the right maneuver. That's the wrong maneuver. Do more of this. No, not more of that, more of this. And that's what we call biofeedback therapy. Ultrasound is simply a picture of the sphincter. So some patients, if they've had a traumatic vaginal delivery, they may have actually had a tear to their anus. In the worst case scenario, sometimes patients come to us with a completely torn anal sphincter. Fortunately, not too many, but that's a sign of a very, very traumatic delivery. And so we're able to assess for and measure whether a tear to the sphincter is a part of the problem. And sensation testing, this is something that's often relevant in endometriosis. We talked about sensitivity. Sensation testing is where we blow a balloon up in the rectum. And we ask patients, when can you feel this balloon? When do you feel like you need to go to the toilet? When are you desperate to go to the toilet, or when are you uncomfortable? And a lot of patients with chronic pelvic pain and endometriosis, they can't tolerate much in the balloon at all. And consequently, that then leads to urgency, doesn't it? Because they've got a small amount of stool in their rectum. They're getting pain because everything's so sensitized and they need to get it out. And then they've got pain and urgency combined and suffering related to that. So those tests do provide us with more information, as I said, and patients often find, being able to see the results also very helpful.
All right, let's get on to management. Oh, Sheree, you're looking like you.
Oh, no, that's a couple of questions. And again, this shows my bias because we were just talking about notice, like that interoception, I guess, and what the patient is feeling. Like, do you see any neurodivergent patients, and is their experience different or challenging?
Yeah.
Like,
I mean, yeah, obviously we do see neurodivergent patients, and I talked, I talked before about the brain-gut axis. The term I like is the brain-pelvic floor axis, because I think, like I said, your subconscious brain and this part of your body, your pelvic floor, are intimately related. And what's going on here manifests with what's going on down in your pelvis. So with neurodivergent patients, sometimes that they can also have dysfunction related to, I mean, I'm only a colorectal surgeon. I'm not a psychologist. I'm not a psychiatrist, but there may be some kind of occasional inner turmoil or distress, and this can manifest in this part of their body. Patients with what we talked about before, intussusception, so the rectum's lost its support because of perhaps traumatic vaginal delivery, or perhaps because of straining for years and years and years and stretching out of tissue, the rectum starts collapsing down, and what we call intussuscepting. So those patients may feel that. So they may say, look, I feel a pressure or a bulge in my rectum. They may even say, hey, Chris, it feels like something's trying to come out of my anus, because that's literally what's actually happening. They literally will describe that. They may also describe mucus leakage after going to the toilet. So we call that post-defecatory mucus leakage. So like I talked about before, go to the toilet, you think you're clean, but then you later find a little bit of mucus leaks out because the rectum has actually dropped down into the anus, and the anus reflexly relaxes and a bit of the mucus from that rectum leaks out. And so those are the symptoms that patients may describe. And some patients may have advanced intussusception or advanced internal prolapse and not have many of those symptoms, and others may. In terms of neurodivergent patients, I mean, I don't know that they'll have more or less of those symptoms, but they may describe them in a different way, perhaps. And I think it's important to be sensitive and open to how a patient perceives something.
Mm-hmm.
Yeah.
So I knew we would run out of time in this episode. So let's talk about what to do. Like, what's our management? Can you talk us through, Chris, what are the first things that you're thinking you need a patient who's struggling with this stuff to do?
Yeah. I think the first thing is to be aware that there's help. Be aware that there are people who spend a lot of time in this field, and no matter how bad the symptoms are, there's probably things we can do to make your symptoms better, and it doesn't always involve surgery. So a lot of people, they think, oh, I'm coming to see a colorectal surgeon, that means I'm getting an operation. The best outcome I can get is when I don't have to operate at all. And that's the majority of the time. The majority of the time we try to avoid surgery because we can get people better with non-operative strategies. Not just, there is a role for surgery. And like I said before, these patients do often do well when they do have an operation. I think it's really to find the right person. So start off with a GP who is able to, you're able to develop a rapport with. And I think for GPs as well, to be able to establish relationships with specialists who are the right kind of people who are able to provide good multidisciplinary care for these complex disorders, including specialist pelvic floor physiotherapists, psychologists, dietitians, etc. So I think a lot of it is just we need more awareness, and I think in particular awareness that these symptoms don't have to be put up with. We can't guarantee cure, but we can probably guarantee that we can make your quality of life a lot better and make these symptoms much more manageable. So you manage them rather than them managing you.
And in terms of things that we give, and of course we're talking about people with really severe life-altering bowel issues going on. Often I will go to an osmotic laxative first.
Yeah.
So that might be a Movicol or an Osbalax.
Yep.
Dr. Chris, is that going to make someone's bowel lazy, and do they need to be sparing about their use of these things?
Oh, thanks for asking that. So that's a really, really important question, very relevant, and I probably talk about this question every day.
Me too.
Because there's this massive myth out there that laxatives make your bowel lazy, and they don't. It's a load of rubbish.
Yay!
Yay!
There's no evidence ever published in the history of medicine that have shown that laxatives make your bowel lazy, or that laxatives cause cancer or anything like that.
Or are bad for your microbiome. That's the other one that I've heard.
No, there's nothing published that has ever shown that. So if something works, it's just Movicol and Osmolax or Coloxal or Dulcolax or Senna. If that's what works, that's fine as well. These things are all quite safe to take on a long-term basis. And to be honest, what I say to patients is you're less likely to be back in this room if you continue to take that stuff regularly and manage this problem. Often we combine laxatives with a fiber supplement, but it's really important to go about this the right way, not just sort of, take this laxative, off you go. You've got to start off at the right dose. Often I start with a softener. And usually it is a Movicol or an Osmolax, as you say, that the most evidence is actually behind those laxatives. And then gently add in a fiber supplement starting at a very low dose after usually 2 or 3 weeks. And so it needs to be something that's carefully titrated and giving patients lots of options, different kinds of fiber supplements, different kinds of softeners. But usually a lot of patients end up on a combination of those two things.
One of the things that I heard you say in another some professional development that I heard you speak at was find something that works for you and stick with it. And that really hit home to me. And I'm going to tell you in our sort of last few minutes that this is not an evidence-based rule. I have a made-up rule, which is the break-up rule for bowel problems. So, you know, the idea that if you've been with a person romantically and you break up, you need half as much time to get over them as you were together. I have a break-up bowel rule. So if you've had 10 years of bowel problems and you've found something, an Osmolax or a Movicol, which works for you, that is going to be your friend for 5. Because otherwise I have people who go, oh, it's so much better for a week and then I stopped it and now it's back again. So any thoughts on my breakup rule?
I love it. Yeah.
Great. It's completely back up.
I think because there is that myth of like, don't use anything long term.
Yeah.
Because it's going to affect your physiology.
So I've got a couple of things written down that I wanted to make sure we got in before we finish. Poo window. Don't miss your poo window.
Yep.
Tell me about that.
Yeah, respond to the urge. Yeah, absolutely. I think that's part of the Western
That's a T-shirt,
world.
Isn't it?
Don't miss your poo window.
Don't miss it. Well, respond to the urge.
Respond to the urge. You know, there are natural times where we go to the toilet. One of them is after eating, right? As I talked about before, the gastrocolic reflex. So part of the problem, if we oversimplify the Western world, you know, we all have breakfast in the morning and then we get the gastrocolic reflex while we're stuck in a traffic jam on the way to work and we all hold on. And there you go. There's your problem started. So the entire way our Western society and culture is set up is really for bad toileting. We've got too much stress and we're not using our poo window, as you said before.
So Cherie's got a T-shirt that says respond to the urge. And I have a T-shirt that says don't miss your poo window.
Don't miss your poo window. Yeah.
And the last one
But does that happen after food? Is that what you're saying? Because I thought that was just a way to get out of doing the dishes.
The gastrocolic reflex.
Yeah.
It's a thing.
It's a thing. Okay.
Who does that?
Ava. Sorry, Ava.
And the last one I mentioned in my introduction about you, can you please tell us about what do you mean when you say that the anus is just there to keep the flies out?
Oh, yeah, I guess it's a bit tongue in cheek, if you like. But the point I'm trying to make there is that a lot more of the action and continence mechanism occurs higher up at the puborectalis and pelvic floor level than it does at the sphincter level. And so there's this sort of idea in medicine that the sphincter is what keeps us continent. And I think the sphincter and the anal canal have a role, but it's more to reduce that small amount of leakage that I talked about before. Your major continence mechanism is higher up, and I think there's less awareness of those more important pelvic floor muscles and a bit too much focus on the anal sphincter itself. So it's a little bit tongue in cheek, but there you go.
Dr. Chris Gillespie, it has been a joy and a privilege. Thank you so much for joining us for this episode. Patients, people in Queensland will be able to find you at the Queensland Pelvic Floor Centre. Thank you so much for your leadership in this area, and all the best. And perhaps we can have you back again in the future.
I think so. I think there's so many questions, but great explanations.
Yeah,
I think you know, so such a needed podcast. Thank you.
Well, thanks so much. Thanks for the invitation and for the time with you.